Vestibular Ocular Reflex. To maintain a stable perception of the world around us while we engage in normal movements throughout our day, such as walking, we have something known as the vestibular ocular reflex. This reflex keeps us steady and balanced even though our eyes and head are continuously moving when we perform most actions. When we make a head movement, our eye muscles are triggered instantly to create an eye movement opposite to that of our head movement at the exact same speed to readjust the visual world, which in turn stabilizes our retinal image by keeping the eye still in space and focused on an object despite the head motion. The vestibular ocular reflex involves three parts: a peripheral sensory apparatus, which consists of a set of motion sensors, the semicircular canals, and the otolith organs, namely the saccule and the utricle. Which are the otolith organs? The saccule and the utricle. A central processing mechanism. I repeat again, the vestibular ocular reflex involves three parts: a peripheral sensory apparatus, a central processing mechanism, a motor output, which are the eye muscles. Otolith organs are sensitive to linear acceleration and therefore detect the position of the head relative to gravity and head translation. Semicircular canals, however, are responsible for detecting head rotation since these are sensitive to angular acceleration. These organize in a push-pull structure consisting of one coplanar canal on the left side and another coplanar canal on the right side, which work by coordinating with each other. These are the semicircular canals: the anterior, posterior, and the horizontal canal. This is the horizontal canal, this is the posterior canal, and this is the anterior canal. The posterior and the anterior canals combine here to form what is called the crus commune. Each canal ends in an expansion called the ampulla. The otolith organs are the utricle and saccule. Humans have a total of 6 canals arranged in 3 main planes: anterior, posterior, horizontal, on both sides. Each plane has a pair of canals. A canal will get stimulated by head movement towards that canal. When a canal on one side is activated, there is inhibition of the other one during angular head movements. When there are head movements and rotation, the velocity of the movements dictates the difference in firing rate between the two semicircular canals. Hair cells are embedded in a fluid and gelatinous structure called the ampulla in each canal. When our heads rotate, the canal will move relative to the fluid inside of it, which will create a force against the ampulla, causing hair cells to bend. When the head is at rest, the vestibular efferents have tonic discharge. This results in a balance between the semicircular canal pairs. This is the ampulla at the end of each canal, and within the ampulla are the hair cells located in a gelatinous structure. Cases of nystagmus and ocular misalignment may be interpreted by understanding the organization and structure of the semicircular canals and otolith organs within the head. Information regarding linear acceleration, angular velocity, and orientation of the head relative to gravity are all collected by these peripheral motion sensors, and all these happen in a split second. These sensors relay this information to the central nervous system, and here information from somatosensory, that is, carrying other sensory information, is combined with motion sensory information to calculate head orientation. The central nervous system is the central processing mechanism which sends its outputs to the spinal cord and ocular muscles to generate the vestibular ocular reflex. Each semicircular canal has excitatory projections to a pair of extraocular muscles in each eye and inhibitory projections to an antagonistic pair of muscles. In addition to vestibular ocular reflex, we also have what is called the vestibulospinal reflex, which prevents falls by maintaining head and postural stability. It does this by creating compensatory body movements. To attain an even better orientation, this information also goes to cortical structures, namely posterior insular vestibular cortex, for further integration with tactile, auditory, and proprioceptive inputs. Actions of vestibular ocular reflex and vestibular spinal reflex becomes controlled and continuously adjusted as needed by the central nervous system. Vestibular information comes into the brain stem via the cranial nerve 8, the auditory nerve. Signals enter the vestibular nuclear complex located in the medulla and pons. Four main nuclei comprise the vestibular nuclear complex, namely superior, inferior, medial, and lateral. Using first order sensory neurons of cranial nerve 5, most of the semicircular canal inputs synapse at the superior and medial nuclei. The median longitudinal fasciculus is used to send second order sensory neuron signals ipsi and contra laterally to oculomotor cranial nerves 3rd, 4th, and 6th. Lastly, a third motor neuron is responsible for stimulating the extraocular muscles that cause conjugate eye movements. Also, the vestibular system sends information via the inferior cerebellar peduncle to the cerebellum to modulate the vestibular ocular reflex. The flocculonodular lobe and the fastigial nuclei are responsible for this fine tuning. Vestibular data is also processed by the cerebellum, which then aids in the regulation of vestibular reflexes, maintaining posture and coordination. Other connections to the central cortex, the cerebral cortex, thalamus, and reticular formation assist in coordinating efforts between other central networks and the vestibular system, allowing for enhanced spatial awareness. As mentioned, the vestibular ocular reflex works by activating our eye muscles to create eye movements in the exact speed but opposite direction of our head movements to stabilize our retinal images. To recognize the effects of this activation, we must understand the direction of pull on the various eye muscles at play. The horizontal recti are easier to understand than the vertical recti and obliques, which are more complex. The lateral rectus muscle is responsible for abducting the eye, while the medial rectus is responsible for adducting. These are the horizontal recti. The effect of pull on the vertical recti and the oblique muscles changes depending upon whether the eye is abducted or adducted. When the eye is in abduction, the contraction of the superior rectus will elevate the eye and contraction of the inferior rectus will depress the eye. When the eye moves into adduction, there is more of an intorsional movement caused by the superior rectus and an extorsional movement caused by contraction of the inferior rectus. During eye abduction, contraction of superior oblique causes intorsion of the eye and contraction of the inferior oblique causes extorsion, whereas during adduction, contraction of the superior oblique causes depression and contraction of the inferior oblique causes elevation. These are the recti, that is the superior rectus, this is the inferior rectus, that is the lateral rectus, and that's the medial rectus. And then again we have the superior oblique muscle, and of course we then have the inferior oblique muscles. The implication of a disrupted vestibular ocular reflex include oscillopsia and abnormal nystagmus. Oscillopsia results in blurred vision when the head is in motion and objects appear to jiggle and bounce since they do not stay fixed at one point in the retina. Patients are often forced to stop and stay still to read signs. Reading a book may also require great effort since small head movements may cause distortion. Since these patients would need more time to comprehend and process words and letters, undiagnosed children are sometimes wrongly thought to have dyslexia or dyscalculia. Abnormal nystagmus may also blur vision since it causes excessive involuntary eye movements and can be in various directions, side to side or up and down. Individuals with vestibular ocular reflex malfunction are also likely to be clumsy, get motion sickness easily, and have sensory issues, difficulty maintaining balance, and nausea. If the sensory vestibular organs are not fully functional on either side, the brain will receive conflicting signals regarding movement, thereby causing vertigo. Assessment of the vestibular ocular reflex takes place using what is called the Halmagyi-Chourty test, also known as the rapid impulse test. And to perform this, the physician will rapidly move the patient's head in one direction, left or right, and the eyes should remain in place focused on a particular object in front of them despite the head movement. If a patient's vestibular ocular reflex is damaged on one side and when their head turns to that direction with force, their eyes will follow the direction of the head movement before coming back to their focal point, and this would imply some issue in the vestibular ocular reflex. The VOR may also be tested using caloric reflex test, where cold water or warm water is poured into the patient's external aortic canal using a syringe to induce nystagmus. When using cold water, the fast phase of nystagmus should be to the opposite side of the ear filled with water. However, when using warm water, the fast phase of the nystagmus should be on the same side as the water filled ear. If this eye movement is abnormal and not occurring as described in the patient, there is a likely vestibular dysfunction in the side being stimulated by water. Brain death is a complete loss of cerebral function, and if performing the caloric reflex test and the VOR is absent in the patient, this is likely a serious indicator of brain death. The ability to restore VOR function varies. Due to neuroplasticity, it usually improves spontaneously with time and no intervention is needed. There are a few suggested interventions for those who do not recover with time. One is an adaptation and another is an exercise-based treatment program, the vestibular rehabilitation therapy. It is challenging to restore VOR function at high velocities in severe cases of vestibular loss. The goal of vestibular rehabilitation therapy is to practice head and eye movements with different activities and postures. They should repeat movements that stimulate vertigo and continue to expose patients to different types of sensory and motor environments. VOR exercises should start with patients in a seated, still position to assess if there is an aggravation of symptoms such as dizziness, nausea, and anxiety. The exercise can also slowly increase in velocity, and by gradually increasing the intensity, the capacity of the vestibular ocular system will not be overwhelmed. Other methods to rehabilitate VOR function are under development, and for example, researchers found that artificial restoration of the VOR function is possible by electrically stimulating the branch network of vestibular branch in humans. This is a comprehensive overview of the vestibular ocular reflex.